How do we differentiate the approach of chemotherapy versus cellular therapies?
In the past, the traditional treatment for cancer is always chemotherapy after chemotherapy after chemotherapy. But we know that the immune system is built to fight cancers. When we talk about cell therapy, the difference is that you're using live cells as the drug. So you're taking the immune cells from the patient, sending them to the lab. We give them immunotherapy in the lab, we activate them, we make them stronger, smarter than the cancer, and then we infuse live cells technically. Those are live cells that they can still replicate in the patient once we give them back to them.
Welcome to Beyond the Rounds. I'm Dr. Nolan Fisher. Today, we're talking about the future of cancer treatment, cellular therapy. My guest today is Dr. Yazan Samhouri. He's a specialist in hematology and cellular therapy at Banner MD Anderson Cancer Center. By the end of this episode, you will understand what cellular therapies for cancer actually are, where cellular therapies fit in cancer treatment plans, and why the standard of care you learned in medical school is likely already obsolete. Dr. Samhouri, welcome to the show.
Thank you, Dr. Fisher. I'm excited to be here to talk about my favorite topic, cell therapy.
We're talking about some really interesting stuff today. This is like real medicine here.
Mm-hmm.
Yeah. So tell me this, you came to the United States from Jordan in 2014 for your residency. I'm sure that was an absolutely crazy time of your life. How did that journey then lead you into hematology and oncology?
So I've always been perplexed by the science of hematology and oncology. Specifically, I remember, growing in medical school and in the career, learning about coagulation cascades and the benign hematology part of it really got me into the science of hematology and oncology. And then getting into residency and fellowship and learning more about all the subspecialties, meeting different mentors and all that, I ended up deciding that malignant hematology and cell therapy is where I find myself in enjoying taking care of these patients and having fun doing this job long term. Yeah.
So I feel like a lot of people, when they go through medical school, they're interested in either the mechanics of doing something, right? The hands-on process.
Yeah.
Those people end up being surgeons.
Correct.
There are a lot of people that are interested in really the hardcore science behind it. Is that what you found an interest in?
Correct. Exactly. The science of hematology specifically is what drew me into this job. Yeah.
Okay. And I read that you went to Rochester, New York.
Yep.
And you're from Oman, right?
Yeah.
Very different.
Yeah. Very, very different.
Was it a little bit of a culture shock?
Yeah. I mean, weather is different. Landscape is different. Everything is different.
So tell me this then. Whenever you came over, that's now 12 years ago, have you seen cancer treatment change in the past 12 years since you even came over to Rochester?
100%. I mean, things that we did even as a trainee, now we do things differently. Things that I did as a junior faculty after finishing fellowship, today we do things differently. Just the amount of new data or new clinical trials that coming up leading to new approval, like whatever we did 12 years ago when I first started doing this, is totally different with what we do now.
That makes sense. Do you feel like it is almost difficult to stay up on just how much research is coming out?
Yeah, 100%. And if you look at the hematology oncology as a field, it's becoming harder and harder every year to be a general oncologist. And I really admire the people who do that now, because it's just a lot for everything, for breast cancer, colon cancer, even in blood cancers, you have lymphomas, leukemias, multiple myelomas. There's data on a monthly basis coming out for every specialty. That's really hard to keep up. And that's why we're becoming more specialized in what we do.
Yeah, and that makes sense. It almost reminds me of when you're doing standard hospital medicine for common illnesses, right? If somebody has pneumonia out in the middle of Dodge City, Kansas, they don't necessarily need to be sent to Mayo Clinic or Kansas City. They can get that treated there. But whenever the level of care needs to be more specialized, that's when you end up in a cancer center that has specialists such as yourself.
Exactly.
Okay. Well, that makes a lot of sense. Can you tell me then about cellular therapies and what exactly those are?
So cell therapy in general is not a very new idea, because if you talk about autologous stem cell transplantation and allogeneic stem cell transplantation, which we have been doing for decades, those counts as cell therapy. But now when we say cell therapy, we're talking about a newer technology, which is using the patient's immune cells to fight cancers, like CAR T cell therapy, tumor-infiltrating lymphocytes, and these kinds of therapies. So now when we say cell therapy, we basically talk about those kinds of therapies, and those are the newer, I would say, novel immunotherapeutic approaches to treat cancer.
Okay, so two things there. One, previously, when you say using immune cells, prior to that, we were using chemotherapy, essentially.
Correct.
And how do we differentiate the approach of chemotherapy versus cellular therapies?
So, in the past, the traditional treatment for cancer is always chemotherapy after chemotherapy after chemotherapy. But we know that the immune system is built to fight cancers. And then certain advancement came into cancer medicine that really changed how we think of cancers or how we treat them, and changed the prognosis of really difficult to treat diseases. And that led to immunotherapy agents before the cell therapy part, like checkpoint inhibitors. If you hear about Keytruda, Opdivo, and all these treatments, those are immunotherapy, but those are drugs that the patient gets to stimulate the endogenous immune system. When we talk about cell therapy, the difference is that you're using live cells as the drug. So you're taking the immune cells from the patient, sending them to the lab. We give them immunotherapy in the lab, we activate them, we make them stronger, smarter than the cancer, and then we infuse live cells technically. Those are live cells that they can still replicate in the patient once we give them back to them. The difference in cell therapy compared with other immunotherapy, that we rely on a very important function of the immune system, which is the memory function, because those cells are supposed to integrate back into the patient's immune system, replicate, stays there. Whenever a cancer cells comes up, they go there and kill them. So that's why we're looking for one and done infusion for a durable response, and hopefully for a cure, or really cancers we never dreamt to cure them.
Okay, and those are specifically like metastatic cancers and even solid tumor type cancers?
Correct. And we have them for hematologic malignancies, and we have them for solid tumors, different technologies and different targets. But we have them for almost every cancer now. Yeah.
Okay. From what I remember from med school, it seems like cancer cells do pop up randomly in our body, and our body fights them off all the time. It's just that some cancer cells end up, becoming too powerful or growing too fast for our body to fight back.
Correct. So in theory, the immune system should recognize cancer cells and kill them without even us knowing that there was cancer, right? If our immune system is 100% efficient, then we don't have cancer in the world. But we know that's not the case, right? So cancers get smarter than the immune system, where it suppresses the immune system. So those cancer cells, they go to the tumor, they infiltrate the tumor, they try to kill the tumor cells, but the tumor will tell them, you're here, but you cannot work. So that's what happens.
That makes sense.
Yeah.
That makes sense. So when was it then? You said that it's changed even over the last few years. When was it that you saw cellular therapies work for the first time? Especially like these more recent TIL type therapies and CAR T cell therapies.
Yeah, so I still remember our first patient when I was a trainee, when CAR T cell therapy got first approved in 2017, 2018 for lymphoma. I still remember our first patients. A lot of excitement was about that patient, that we are doing this for the first time. It's a very exciting science, a very exciting treatment. It's difficult lymphoma, refractory to everything, and we are going to cure this lymphoma. So that's where I really remember how the first patient with cell therapy that I've seen, 2017, 2018.
Okay. Yeah. And then it's grown, obviously, in popularity since.
More indications, more FDA approvals, more technologies, better CAR Ts compared with that time. So, yeah.
And this takes like really good work with industry, I would guess, and academic centers together. Is that accurate? Is there a lot of crossover between the industry pharmaceutical companies and the large academic centers?
Correct, because those cells, as I said, we take them from the patient, we send them to the lab. This lab actually is with industry, with our pharma colleagues or the pharma company that we work with, where they work on them in the lab. There's some genetic engineering happens, some immunotherapy stimulation to grow them. That takes 3 to 4 weeks, sometimes 5 weeks, until the cells come back to us. So we administer them to the patient, actually.
And when you take the cells back, you're giving them to the patient to say, hey, you've already had these cells, but we're handing you a massive dose of these cells.
Correct. So its number is higher, but also they are more active.
Okay.
Yeah.
That makes sense. Well, I like that case. Can we go to a case right now? And so we can talk about some of the specifics about how this treatment works.
Let's do it.
Let's just say we have an older 60 to 70-year-old male who comes in with a diagnosis of metastatic melanoma, which is a BRAF mutant variant that is metastatic to the liver, the bone, the brain, and lymph nodes. He underwent multiple different resections, immunotherapy, and other targeted therapies. All of these gave him periods of response with eventual disease progression, and he was sent to you to consider the tumor-infiltrating lymphocyte therapy, underwent tumor harvesting from the liver, and that was roughly 4 months prior to when he received the cells. When he received those cells, roughly 42 days after that, he got a PET CT, which showed almost complete response. So is this a typical patient journey through this process?
In metastatic melanoma, technically, we have two types of treatment that can work. We have checkpoints inhibitors or immunotherapy, the traditional immunotherapy, which are Keytruda, Opdivo, the drugs that I talked about. And really, melanoma was the one of the first treatments or first diseases where we used this kind of treatment. And it revolutionized the treatment of melanoma. But they stop at a certain point. They don't work forever for almost all patients. The other treatment strategy is to use targeted therapy for the BRAF mutation that we mentioned. And other than these two things, really there is no efficient treatment that we can rely on. So patients like this, unfortunately, if before cell therapy, our hands are tied.
So these patients were getting a sort of immunotherapy already, where they would see either halted progression of the melanoma or even some regression in the melanoma. And so it probably gave them a false sense of hope for a period of time. And then almost universally, they would start not being as effective.
Correct. For stage 4 melanoma, these drugs will work for a period of time. It could be a month for some patients, could be 5 years for other patients, but everyone will progress on these medications.
Okay, so this patient goes through a couple different medications like that. Previously, this patient's basically out of options.
Correct.
Okay, and then for this patient, what was the process like for getting the TIL therapy, that tumor-infiltrating lymphocyte therapy?
So the tumor-infiltrating lymphocytes is one of the cell therapies that we are excited about, and we're really happy to have it in the Phoenix metro area here at Banner. So what happens is those, from the name, it's tumor-infiltrating lymphocytes, right? So those cells are in the tumor already, as I said. Why did they go there? To kill the tumor cells. But they didn't work because the tumor suppressed them. And we know about this phenomena since the late 80s. We're trying to bring it to the patient advantage, actually. So we take piece of the tumor out. It has to be at least 1.5 centimeter of tumor. It doesn't matter from where. The easiest location, usually, we talk to one of our surgeons, and they take piece of the tumor out. And then we send the whole tumor to the lab, to the company that we're working with. And then they extract those lymphocytes from the tumor. They give them some immunotherapy, which is typically some IL-2, interleukin-2. They grow them, they stimulate them, they activate them. Now they are very active, and they can resist whatever mechanism the tumor has caused them not to work there. And then that takes around 4 or 5 weeks. We get them back to the hospital. We administer them to the patients. But this is kind of whole process that there's a village who takes care of these patients. I'm not talking about physicians, but from the physician standpoint, we have a cell therapist like myself, and we have the melanoma oncologist or medical oncologist, and we have a surgical oncologist. So the three of us will be working with these patients to decide what's the best location of the tumor to get out, who's eligible for these patients from oncology standpoint, but also from the cell therapy standpoint, because those are still intensive therapies, relatively speaking, and we need patients to be in the best shape, really, to do it, or to optimize the patient really very well from cardiac standpoint, lung standpoint, liver standpoint, kidney standpoint, to make sure they can tolerate such treatment. But other than the physicians, you have an infrastructure like what we call the cell therapy lab, the cryo lab, where they ship the specimen out to the company, receive the specimen. We have to have specific freezers, for example, where we can put these cells in. We have the inpatient team from nursing, from our APPs, like a whole village who takes care of these patients. Even when the patient gets to the hospital, we admit them, they stay in the hospital for 2 to 3 weeks to complete this therapy, recover from it, and then they go home. So it's really a whole process to do it.
Yeah, it's an intense process, is what it sounds like.
Yeah.
And it involves a lot of different people. It involves a lot of different parties too. It's not just the hospital system. Like we talked about before, it's sending it out to the industry folks.
Yep.
It also involves, from what it sounds like, a lot of team members outside of the cancer team. So like primary care doctors, cardiologists, nephrologists,
100%.
everybody optimizing the patient. It involves a lot of effort too on the patient's behalf to make sure that they're, as healthy as possible for this treatment.
Correct.
Okay. And then from there, when you say this treatment is given to them and they're in the hospital for 2 to 3 weeks, is this an IV treatment? Is this some sort of injection? How is the treatment administered?
So it is an IV. So the cells will come back like receiving any blood products. We are giving blood transfusion or platelets. It will be in a small bag. Billions of cells will be there, actually. How do we give it to them? There's 3 stages, actually. We give some sort of chemotherapy for a few days, but that's not meant to treat the cancer.
Mm-hmm.
It's meant to prepare their body for the coming cells, because we need some room and we need to reverse the unfriendly immune environment that the cancer has created to another friendly one so the cells can work.
So you're basically knocking down the barriers.
Correct.
Or you're decreasing the overall immune system that's ineffective at this point.
Correct. So
to make room for your new cells.
Yeah. So we're removing parts of the immune system that can suppress the cells that are coming, and the parts of that is needed for these cells to work, they go up, actually. So
okay, well, I'm picturing in my head, this may sound ridiculous, it's almost like the magic school bus,
yeah,
where they go inside the blood vessels. I picture these cells are like hitting the gym and they're multiplying them, and the IL-2 is actually part that's increasing the size of the muscles and making the cells stronger. And they're recruiting even more people or making clones or copies of those cells. Is that right?
100%.
Okay. And then when you push them into the IV, you now have a space where there's not cells getting in the way. And these cells are going to go in. They're going to be much more effective and have kind of strength in numbers against the tumor that they didn't have before.
Yep.
Okay. What's the response like for this? So is this something that works every time? Is it something that works 10% of the time? Where are we?
So there's nothing in medicine works 100% of the time. We wish we have that number. But what we have now is the response rate is between 30 to 40% of patients will have some sort of response, either partial response or complete response. Now, when you mention the number 30, 40%, that might sound a low number, right? But before this therapy, the number is 0% because there was no treatment that could have worked, right? Mm-hmm. So we're starting at 30, 40%. We're still we're working on getting it better and better. We're doing more research to increase this number from 30, 50, 70, hopefully reaching out to 100%.
And do you feel like part of that improvement is the tool and part of it is how we're using the tool?
Different things. So we are working on the technology itself, the cell itself. So there's more genetic engineering to the cells. The other things we're trying to make either the chemotherapy before or the IL-2 that we give after better or easier to give. So we have more, we have this treatment for more patients because, as I mentioned, we need the patient to be perfect. But if you make it easier, you have it accessible to more patients, you can cure more patients.
Sure.
Yeah.
And so when this treatment's given, this sounds like it could be a very metabolically demanding process for the patient. They all of a sudden have a lot more immune cells that their body has to supply energy for. Is this tough for the patient? What's the typical patient experience for this treatment?
So the tough part is the chemo that we give before, not the cells, actually. So the chemo still have some toxicity. The cells themselves will replicate, but when we did the research to get it approved, we knew what's the right dose or the perfect dose to give. So we're not giving too much that we are over burning the patients or the immune system, because if the cells continue to proliferate without control, then the patients will run into hyperinflammatory syndromes where where they would have fevers or low blood pressure, low oxygen. It's like they are septic, technically, but without a bacteria or a virus. But that does not happen because we spent decades trying to study what's the right dose, and that's what we're giving to the patient now.
That's interesting. Let's move on to a second case, okay? This is going to be an adjacent type of case. This time it's a 45-year-old female. She has diffuse large B-cell lymphoma. She relapsed after standard chemo immunotherapy, and she received CAR T-cell therapy. The initial hospital course was complicated by grade 2 cytokine release syndrome, but she successfully managed with, hear me out on this one, tocilizumab. There you go. Yeah, exactly what you said. And is now in remission.
Yeah.
How does CAR T-cell therapy differ from the TIL therapy that we were just talking about?
So when we talk about cell therapy in general, we have 3 technologies technically. It's like A, B, and C of the same drug technically, but it's how we manufacture them. It's a little different. So CAR T, the receptor that we put on the cell surface, so there's genetic engineering to it. So we have to change the cells technically to put a receptor that binds to the lymphoma. So we are teaching the CAR or the T cells. We're teaching the T cells how to bind to the cancer. Cell therapy, there's no genetic engineering. Those are naturally occurring cells. Why? Because we took them from the tumor. So we know that they recognize the tumor because we took them from there. We don't even know what do they recognize on the cancer. But the CAR, we put something on the receptor, on the T cells, to teach them what to recognize on the tumor. That's basically the main difference. There are more nuances into that and what type of antigens every cell recognizes and all that. But I think the main difference is that we're teaching the CAR T, the genetic engineering in the CAR T. There's no genetic engineering in cell therapy.
That makes sense. And does the CAR T-cell therapy tend to be more for the blood cancers?
Correct.
Okay, like leukemia, also lymphoma as well?
Yep. There's a lot of lymphomas, leukemias, and multiple myelomas. We have multiple products approved. I won't say CAR T more for blood cancer. I think we're not successful having CAR T for solid tumors. It's more difficult for solid tumors to have a CAR T, but it's easier to have TILs for solid tumors. I don't think we spend a lot of time working on TILs and heme malignancies because we have CAR T working very well. So we're trying to improve that part first.
Makes sense. Does the CAR T cell have a similar percentage of remission or treatment as the TIL therapy, or is it even better?
No, even better, actually. And in general, if you think of it, it's different compartment, right? So when you give the cells in the blood and you're treating a blood cancer, you have easy access, right? But melanoma can be anywhere. Can be in the skin, can be in the lungs, can be in the brain sometimes. So the compartment is more difficult for melanoma. So I think it's not fair comparison here. It's not apple to oranges, but in lymphomas and leukemias, the response rate can be up to 80% actually, and we have a cure rate of 30 to 40%, which we have patients living 3 to 5 years after treatment free of lymphoma. That's when we declare the cure for them actually.
That's incredible.
Yeah.
So it's almost like the CAR T cell is more spread out throughout the blood, and that's good if you have an issue in that area.
Yeah.
Whereas whenever it is a targeted issue, it's almost like taking ibuprofen and expecting it to help your knee pain. It may help, but you also could get a more powerful treatment like a steroid injection directly in the knee, and that would be a better treatment option.
Correct, 100%.
Okay, that makes sense as well. Let's talk about cytokine release syndrome. You explained it before. It's almost like you are ramping up the immune system to fight an infection that isn't there. Is this something that's common with the CAR T cell or the cellular therapies or the TIL therapy?
So cytokine release syndrome, probably we heard this word also during COVID, and we saw about these cytokine storms that happen. So it's all coming from the same principle where the immune system is hyperactivated to a degree where we don't need it to fight infection or we don't need it to fight cancer, but it's causing more harm than benefit. It's more common with CAR T cell therapy compared with others cell therapy. So we don't see it a lot of TILs, we don't see it a lot with TCR, which is the third technology, but we see it specifically with CAR T cell therapy. Usually, as I mentioned, it's like sepsis, fevers, low blood pressure, low oxygen, patient gets rigors, joint pain, all these things. And we give them something to suppress the immune system because now we know once we give the CARs to the patient, they proliferated more than what we need them. So we suppress them to bring them to the level where it's only needed without over-suppressing them that they're not working.
That makes
anymore.
sense.
Yeah.
Do you use that medication that we talked about?
Tocilizumab. Yeah.
Okay. And that brings the immune system down to a more manageable level.
Correct. It targets IL-6, which is one of the important cytokines that contribute to the toxicity. And we don't need it a lot for the efficacy.
Okay. Is this common?
It's very common.
Very common.
Very common. We say some of the products, almost every patient we give CAR T cell therapy gets some sort of cytokine release syndrome. It could be 80 to 100% actually. But some patient gets just one fever, you give Tylenol, it goes away, and that's it. It still counts as CRS. And some people will need the TOSI. Patients who need the TOSI, not very common. So the severe or the high grade of CRS, it's not very common. Probably, I would say 15, 20% of patients.
Okay. And this is a typical patient that is there any typical patient for it? Like patients that may be in better health overall are more likely to have this exaggerated immune response, or is it the other way around?
No, this is something we're still trying to study and understand better. So far, we know that the higher disease burden going into the treatment, so the larger the lymph node for lymphoma, for example, the more leukemia it's there going into treatment, because there is more cells that these CAR T will attach to, and the activation will be kind of more robust. They get more CRS. But this is one factor among probably 10 others that we're still trying to understand.
So it basically could be from not only the treatment itself, the amount of cancer present, the response to the treatment, and then other variables which we really aren't sure about.
Correct. Yeah.
Okay, that makes sense. Let's do one more case.
Mm-hmm.
All right. This one is a 32-year-old male. He has high-risk acute myeloid leukemia, and he underwent an allogeneic haploidentical stem cell transplant. First off, can you explain what an allogeneic haploidentical stem cell transplant is?
Yeah. So when it comes to allogeneic stem cell transplant, we do matching between the patient who's the recipient and the donor, right? Because we're getting stem cells from another person to the patient. Now, we have different types of donors. It depends on the degree of the match. Fully matched donor, that could be sibling, usually a twin sibling. It's basically common sense that to be fully matched because they share everything. And there is half match. So, for example, if we have patients who didn't find a fully matched donor, we test the children, sons and daughters. The son will take half of the genes from the father, half of the genes from the mother. So haplo, which means there's half match to his father or to the recipient. So that's a kind of a relatively newer donor source that expanded the donor pool for our patients. So we're able to do more stem cell transplantation. We were worried about it in the past to do it because more complications can happen with half match without fully match. But we have advancement in the supportive therapy or preventing a graft versus host disease that allows us to use it as a donor, actually.
That makes sense. Do you feel that the process of the stem cell treatments has gotten easier or less burdensome on the patients?
It definitely got way easier compared with before, mainly with us understanding how we can prevent the complications. So we're not waiting for the complications to happen and then try to dealing with it. So now we know how to better prevent infections. We know better how to prevent serious complications like graft versus host disease, some of the liver and lung complications as well.
Okay. And the process of getting a stem cell transplant is still very rigorous, right? Does it involve still significant immunosuppression and isolation? And then receiving those stem cells is still potential for side effects or body not reacting appropriately to them?
Correct. So it's still an intense procedure. Still, we worry about, there's a high risk, despite all the advancement, there's high risk of mortality, or it's a treatment-related mortality. But this number went down really significantly. There's a lot of chemotherapy that comes with it. There's long hospitalization, almost sometimes 3 weeks to a month. They have to be on immune suppressants afterwards to prevent graft versus host disease. That puts them at risk of infections. So, but again, we're I think if you look at stem cell transplantation today compared with just 5 or 10 years ago, we are way, way better. It's way easier procedure on the patients for sure.
Makes sense. But it still requires a period of time where they're on medication prior, and then, like you said, a 3 or 4 week hospitalization.
Yep.
The period after where they're on immunosuppressants to make sure they don't have that graft versus host disease, is that forever, or is that a short period of time?
Not forever. It depends on the disease, the indication why we did the transplant, and it depends the donor source, and depends if the patient develop any graft versus host disease or no. But it doesn't happen forever now.
How satisfying are the leukemia stem cell transplant patients that go through all of this?
I mean, you cure really life-threatening diseases using stem cell transplantation. So it's very, those patients are always grateful. They know that they have to go through a rough patch first to cure this disease, but it's always satisfying for us as a team and for them and their families.
Let's talk about a little myth versus medicine now. Okay. And one of them specifically, when we're talking about leukemias and bone marrow transplants, some things that people have said before are, hey, sometimes the cure is actually worse than disease, the actual disease.
Yeah.
How do you feel about that?
I mean, it's all the decision we make on a daily basis, it's risks versus benefits, right? So when we reach to a degree where the cure is worse than disease, we don't recommend even the transplant, or we tell the patients, unfortunately, you are not eligible. So doing transplant per se does not necessarily mean the cure is worse than disease with good patient selection from the beginning. And this is something we have protocols and we have criteria. So once we decide to move on with a transplant, then they need it, then that's the cure, definitely better than the disease.
That almost reminds me of patients with aneurysms, like abdominal aneurysms, like aortic aneurysms. It's at some point you have to make the decision, is the surgery going to be less likely to harm you than the aneurysm? And that sounds similar to what you're talking about here.
Which is typical medicine. Every decision we make, even if you're prescribing antibiotics or the pain treatment that you're doing, is it worth the risk or should we hold off? Right?
Is the juice worth the squeeze?
Yeah.
Okay. I like that. The next myth or potential truth, you tell me, clinical trials are a Hail Mary.
I think that's misconception. Clinical trials are there to advance medicine. We shouldn't wait for every treatment, especially in cancer medicine, to fail before we refer for a clinical trial. And this is, I'm a clinical trialist, and I'm a true believer of this thing. We should always look for clinical trial for patients, right? It doesn't need to be, okay, I'd go for treatment A to treatment B to treatment C to treatment D. I ran out of the option. Let's send the patient for a clinical trial. Because at that point, probably they are not eligible because they got a lot of treatment. They got sicker. Clinical trials are very, so we have seen everything we talked about today, from cell therapy, from the other treatment, even the traditional chemotherapy. They reach the patient just because of doing clinical trials, right? Mm-hmm. So it shouldn't be Hail Mary. Clinical trials provide access to treatment that can change the face of medicine in general, not only cancer medicine.
So not only should oncologists or general oncologists stay in the know about clinical trials, it almost sounds like if you are a primary care doctor, you should at least have access or be aware to where these clinical trials are and what's going on. Is there a way that that a primary care doctor or even a patient that knows they have a form of cancer is able to look up these clinical trials?
The easiest way to do that is clinicaltrials.gov. That's openly accessed to everyone. You can search by keywords, by the cancer type, by certain type of treatment, and you will have all the clinical trial that is close to you or wherever it's available, actually.
That makes a lot of sense. Our approach for a lot of things in medicine can be complicated, but I think one of the things that holds true through pretty much any specialty is the more treatments that you've had that have failed, the more likely the next treatment will be to fail.
That's a general principle.
And so if your clinical trials want to be real hard science, they can't have too many confounding variables.
Yeah.
And so getting the patients into the clinical trials early is actually better for the research and potentially better for the patient.
And other treatments are always available to give it any time, right? But sometimes you lose the window to put a patient on a clinical trial. Yeah.
All right. Well, one more.
Mhm.
Watching and waiting is doing nothing. How do you feel about that?
So that's where the cure can be worse than the disease, actually. So for certain types of diseases we deal with, a lot of leukemias and lymphomas that we call them low-grade or indolent lymphomas, we don't treat them unless they're causing problems. Problems means low counts, symptoms, very large lymph nodes that is compressing on a vital organ. If they don't do that, we don't touch them. And that's proven by clinical trials or by research that if you intervene early versus late, we don't really change the outcome, but intervening early without the need, you might cause harm for the patient. So that's, again, the balance between the risks and the benefits.
That makes sense. We also talked about systems earlier, right? How big of a team it takes to just provide this cellular therapy.
Yeah.
Several physicians, nurse coordinators, obviously hospital staff, the staff along with the companies that we use. When we think about symptoms and state-of-the-art treatments like this, how do we get patients access to them? We talked about the clinical trials. How do we get these treatments into more patients that need them?
So this is something we're really continue to work on all the time as a community, as hematologists, cell therapists, because we really need more patients to have access to these. In lymphoma specifically speaking, those are curable treatments. They are not there just to palliate treatment. So if the patient doesn't have access to it, then the patient doesn't have access to a curative treatment. And this shouldn't be the case. But you are right that this treatment does not happen everywhere. You need the infrastructure, you need the building, you need the cell therapy lab, you need all the staff that are experienced to deal with this, and hospital that is licensed to start with to administer this therapy. Things we were able to help with was finding a way to provide lodging, transportation for patients who live far. And that's there's some our industry collaborators who provide that, and we have fund as hospitals as well. We can help these patients. That's technically what we can do. But if the patient cannot drive, doesn't have the social support, unfortunately, this is not a good treatment for them.
What advice do you have to primary care doctors that think they have a patient that would benefit from this treatment, or think they have a patient, or patients even that think they may benefit from this treatment?
So it's just important to know about these treatments available around in the community or in the area. So here in the Phoenix metro area, for example, it's important to know that Banner, MD Anderson, and Gilbert, we are able to provide all kinds of treatment that are FDA approved, cell therapies, or even things that we think is going to come in the future under clinical trial. So just knowing which place around the area that can provide access, and having basic understanding to explain it to the patient, to ignite the first excitement about sending the patient there.
I feel like a lot of different specialties, when you're dealing with this specialized of treatment, will often partner like Banner did with MD Anderson, but there may be a clinical trial that includes patients from all different types of large medical centers around the country. Do you deal with that?
Yeah, 100%. So we have these clinical trials that can provide access to these therapies to really patients with a variable diagnoses. And just to break the news that now cellular therapy, we're not using it only for cancer medicine. Now we're having clinical trial to use CAR T-cell therapy for lupus, for rheumatoid arthritis, for rheumatologic diseases, because again, we need something to suppress the immune system. So cell therapy is getting from heme malignancy approvals to solid tumor approval, and in a few years it's going to be approved for rheumatologic disease. So everyone will be involved in caring for these patients.
Let's do some rapid fire questions.
Okay.
Let's have some fun.
Mm-hmm.
All right. Okay. First one. What is the one lab value when you're seeing a patient that you find yourself immediately drawn to?
Probably LDH.
Why is that?
I'm a lymphoma guy. LDH is a tumor marker. So high LDH means bad news. Good LDH means good news for me.
Why does LDH mean bad news?
LDH goes up when the lymphoma is active. So it just reflects the activity of the lymphoma. So if we give treatment, LDH goes down, we're happy. We give treatment, LDH does not go down, then we probably need to look into other reasons.
I will look at LDH differently. Yeah. What's the most exciting drug that you've seen approved in the last, let's just say, 12 months?
So in the last 12 months specifically, I would say cell therapy for melanoma.
What is the best part about your job?
Bringing innovative therapy and bringing hope to help patients with really difficult to treat cancers. So I think just having the opportunity to provide that to help patients and families, that's the best part.
If you could go back and talk to yourself when you were an intern in Jordan, what advice would you give yourself?
Medicine or outside of medicine?
Either.
I probably started playing tennis earlier.
Yeah? When did you start playing tennis?
Just probably 6 years ago.
What is it that you love about it?
Oh, I love everything about it. I love the coordination part. There's a brain-muscle coordination, the exercise, the friendship that you develop on the way. It's a great sport. Yeah.
The biggest takeaway we have is that cancer treatment is moving, and it's moving away from the chemotherapy world where you're doing a lot of damage to people and cancer to the immunotherapy where you're targeting the specific cancer. Would you agree with that?
100%.
Okay. The other one I have is that immunotherapy, while it does sound like it is the future, it's actually here now. And we've been using it for perhaps over a decade to treat different blood cancers. Anything else that you want patients or you want primary care doctors to take?
I think you're spot on. I mean, chemotherapy after chemotherapy after chemotherapy is not the approach anymore in cancer medicine. We're moving immunotherapy in some diseases, even from the first line of therapy, like melanoma. We don't use any chemotherapy at all. So you're spot on, and this is probably the main takeaway from today.
Okay. How do people refer to you?
You can go to bannerhealth.com, the website, where there's always a link, or find a phone number, call us. If anyone in need for a consultation for cell therapy for any indication, we'll be happy to help.
Okay. And we'll put that in the show notes at the bottom of the podcast so that way people can find it. I just want to say thanks to everybody for checking out the podcast today. If you enjoyed this, please consider subscribing on whatever platform you're using. This means a lot to us. I'm Dr. Nolan Fisher, and I'll see you on the next episode of Beyond the Rounds. Thanks for checking out this episode of Beyond the Rounds. As always, we hope you got some clinical insights that you can take back to your patients. If you enjoyed this episode, we encourage you to follow us on YouTube or wherever you get your podcasts. We'll see you next time.